Welcome to today's bite-sized sessions on urine formation. This is a favourite topic in most exams, both nursing and medical, because it tests your understanding of renal physiology and your ability to connect structure with function. So we're going to break it down nice and clearly. Urine formation is all about maintaining homeostasis, keeping the internal environment stable. The kidneys work to filter blood, remove waste, and regulate water, electrolytes, and acid base balance. This process happens in three main steps: filtration, reabsorption, and secretion. We'll start at the glomerulus, a tuft of capillaries inside Bowman's capsule. Here, blood pressure will drive plasma through the filtration membrane. Large molecules like proteins and cells get left behind, while water, glucose, ions, and urea pass through. Filtration is driven by net filtration pressure, which depends on glomerular hydrostatic pressure, so the pushing of fluid out, blood colloid osmotic pressure or oncotic pressure, which is the pulling of fluid in, and then capsular hydrostatic pressure, which is the resistance of filtration. When people get stuck on renal filtration, it's usually not because the concept is hard, it's just because the forces get blended together. So let's separate them properly. Hydrostatic pressure and oncotic pressure do completely different jobs. One pushes, the other pulls. Hydrostatic pressure is simply physical pressure, it's blood pressure. In the kidney, it's the pressure of the blood inside the glomerular capillaries, and its whole purpose is to push fluid out of the circulation and into Bowman's space. And the kidney is actually engineered to amplify this pressure. The afferent arteriole is relatively wide. The efferent arteriole is narrower. So blood enters the glomerulus more easily than it leaves. That creates a high hydrostatic pressure, and that pressure is the main driver of filtration. Oncotic pressure, on the other hand, isn't about pressure in the usual sense, it's about proteins. Plasma proteins like albumin can't cross the filtration barrier, so they stay inside the capillary and create an osmotic pull that draws water back into the bloodstream. So now you've got two opposing forces acting in the same place. The hydrostatic pressure in the glomerular capillaries is pushing fluid out into Bowman's space, while oncotic pressure inside those same capillaries is trying to pull fluid back in. On top of that, once fluid enters Bowman's space, it creates its own hydrostatic pressure that also pushes back against filtration. So that's another opposing force. What matters, though, is the balance. Under normal circumstances, the pushing force from glomerular hydrostatic pressure is stronger than the combined pulling force of oncotic pressure plus the back pressure from Bowman's capsule. That's why filtration happens. One really good point, and this is something examiners love, is that oncotic pressure inside the glomerular capillary actually increases along its length. As fluid gets filtered out, the proteins become more concentrated, so the pull back into the capillary gradually gets stronger. Even so, the overall balance still favours filtration across the whole glomerulus. The next step is tubular reabsorption. The filtrate moves through the renal tubule, the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and then collecting duct. Here the body reclaims what it needs. The proximal tubule reabsorbs about 65% of filtered water and sodium, plus glucose, amino acids, and bicarbonate. The loop of Henle creates a concentration gradient. Descending limb reabsorbs water, and ascending limb reabsorbs sodium and chloride. And then the distal tubule and collecting duct fine-tune the reabsorption under hormonal control. Key points to remember in terms of hormone include aldosterone, which increases sodium reabsorption and potassium secretion, and antidiuretic hormone, which increases water reabsorption by making the collecting ducts more permeable. This is where the kidneys really show off their precision, adjusting water and salt balance minute by minute, like a live process. And then finally, we reach tubular secretion. Secretion adds extra waste products into the filtrate, things like hydrogen ions, potassium, and certain drugs. This step helps regulate pH and remove substances that weren't filtered earlier. This is where the kidneys make sure that nothing unwanted slips through and everything that we need to get rid of goes out into the urine. By the time the filtrate reaches the collecting ducts, it's officially urine. It flows into the renal pelvis, down the ureters, and into the bladder for storage. The kidneys are filtered about 180 litres of plasma per day, but only about 1.5 litres will become urine, which is pretty efficient. So the biggest message, though, is that urine formation isn't just about waste. It's about balance, precision, and survival. When you think of the kidneys, think of them as master regulators keeping your internal chemistry in perfect harmony. Understanding nephron physiology isn't just theory. It's how we recognise why patients with acute kidney injury stop making urine, why chronic kidney disease leads to fluid overload and electrolyte imbalance, and ultimately how we intervene before that physiology spirals into critical illness. If you can understand urine formation, you can understand acute kidney injury. because when filtration drops and the tubules fail, the body can't clear fluid or potassium, and that's when patients tip into overload, acidosis, and life-threatening hyperkalemia. This is what helps you ace exams and nail clinicals. Follow and subscribe for more bite-sized breakdowns that actually make clinical practice click.